So this morning, Priscilla is going to give us an in-service on dirty basin technique, something that I think we could all use a good review on, just to go over the proper way. So the PowerPoint, I will send the PowerPoint separately from the video, just so you all know. All right.
There's a lot on that PowerPoint. I'm not going to read through it. There's a lot on there. So I'm just going to kind of generalize it, but Drew's here as well in case anyone has any questions about the staplers. Drew's here, and he's going to also go over staplers if anyone has any questions. I'm not going to scream. That's why there's a PowerPoint on the table, Eric. You go ahead and look at that. Okay. So what is dirty basin technique? It's isolation technique. Why do we do it? Why is it important? Why do you keep hearing about it? It's not just done in colorectal. It's done in other specialties. You're going to see it in ortho. If there's a fracture, Dr. Ramsky, correct, will debride the wound and he'll say these instruments are dirty. That is dirty basin technique. You're doing it in every specialty. We do it for cancer cases, right? Dr. Desai is taking a melanoma and he has plastics coming into close. That's dirty basin technique. What you use to remove the tumor, you're not going to use to close the tumor. It's our responsibility to do it. The doctors are not going to do it. They may tell you something's dirty, but they're, at the end of the day, they're doing their surgery. They're not worried about if you're giving them something dirty or clean. So that is something that we need to be doing. Staplers, luckily, our staplers, many of the staple loads come off. So you're only really cleaning one. Maybe some robotic staplers, but really only one stapler that we need to clean. So, you know, I know a lot of people like to use the big basin in your dirty basin to like swish the stapler. I don't do that. It takes up most of the room in your dirty basin, and I don't really think that it cleans the stapler that well. Can I use one here?
Yeah, please.
So if you're doing this, you need to have a certain amount of water in there anyway, and you're swishing around and you're getting your instruments dirty. And if you have your labs outside of your boat here, how do you guarantee that you're not getting water on your clean labs and on your clean instruments? You can't. So I use the bulb and I just kind of lavage into the blue. It's a lot more contained. When you take the load off, your hands are dirty. The surgeon's not dirty, right? Because you're giving them a clean stapler. They're cutting across the bowel and they're handing it back to you. They're not touching the load. They're not touching the bowel. Now you, as the scrub nurse, are taking off the load and then reloading. Your hands are dirty, right? Because you're the one who touched that load because that cut across something dirty. So I would put this down then, and if you're no longer doing dirty, take your gloves off and put a new pair of gloves on, right? Does that make sense? Anybody have any questions with that? Cleaning, changing your gloves. I have at least 5 pairs of gloves that I start with. I change my gloves a lot.
If you're changing the reload multiple times, can you just take a lap too and then toss the lap off?
Recovery and turnover, OR2, recovery, OR2.
If there is a lot of bioburden on your stapler, like you're not going to give that back to the surgeon with a fresh load. Wipe it off and then just throw the lap off the field. Absolutely. But if you're then done with this, you're done with your instruments, you're done with dirty basin, change your gloves. The doctor's not going to change their gloves because they're not doing anything dirty initially. When the bowel is open, that's when they're dirty. Does that make sense? Okay. Instrument-wise, when you're starting your anastomosis, you're bringing up your Alice's, you're bringing up your Babs, you have them on your Mayo. When I get those instruments handed back to me, I don't put them on the Mayo. I put them right in the dirty basin. And that's why I have a roll towel in there. So if they ask for that instrument back, I take it out of the dirty basin, and that's what I give to them. Does that make sense? So not to say that you can't use your Mayo, you certainly can, but if you don't have to, I try to keep everything as isolated as I can. Does that make sense? I know it's a lot. So at the end of the case, now you're done with your dirty, right? It's time to close. some surgeons will take their gowns off, some will take new gloves. I have my clean closure here, right? I've set this aside in the beginning of the case. It hasn't touched anything, everything's clean. So my Mayo stand gets, now these aren't green, but I lay down a green towel on my Mayo, regardless if it's clean or not. Now I have a clean towel. I take what's out of my kidney basin, lay it out, and then that's what they use for closure. Does that make sense? You don't have to take the towel that's on the Mayo off. Just put a clean towel down. And it has to be green, because we can't have any blue ones on the field. It's against policy. Any questions with that? What goes in the basin? Any questions with closure?
Are you like sticking your finding drivers up, against your finding drivers for your dirty stuff, your closure?
So a lot of the doctors that I work with, and some like the skinny, most of them like the heavier drivers for closing and for suturing. So you may get into where you need 2 extra ones. So you can certainly use the ones from your closure, but then I would call for 2 heavy ones for closure. The skinny ones are really for smaller needles. So if you're giving like an SH or a CT1, you're gonna want something a little heavier. Make sense? Any questions? Now, when you're not gonna do dirty basin is during a GYN procedure. So those abdominal hysterectomies, that group likes to have that closure set up aside. So you know that Mayo with the closure tray and all of those extras, that's what they use to close with. Any questions? Comments? Anyone can stay, I'll show you whatever.
Priscilla, I've seen many different variations of how to do GYN procedures.
Yes.
So the standard here should be, so your if you're doing laparoscopic, but you're going down below.
Right.
How do you do it?
So that is a different table. So you have your table with your vag hispo, so that's your dirty, right? Your top is gonna be, sometimes they'll do 3 Mayos with laparoscopic instruments. So they will loosen everything up abdominally, but then down below they're taking it out and closing the cuff. So you already are doing your clean dirty. So your clean is at the top, your dirty's at the bottom. And then you have 2 counts then.
If they don't know if they're gonna close from down below.
Right, if they don't know that they're gonna close from down below, then I would do the clean Mayo. So it's a separate Mayo, separate count with your wound closure and all of your extras, bovie, suction, whatever you need for that. And those things are on the cards right now, so for GYN. Yeah, okay. Like the wound closure tray, what they do, what they need, is all for the GYN docs, is on there.
Do you favor Richardson for the, like a Richardson in the beginning?
Yep, same small rich, so they can use it at the beginning, but then when they start to get dirty, I act like I don't have it anymore. Unless they really, really want it. Don't get yelled at. Give them what they want, but then you may need to call for another one at the end. Am I forgetting anything? That's my setup. I like to keep my clean stuff as far away from my dirty basin as possible. You'll see other variations, just what I do. Probably forgetting something. But you guys can always ask me, I'm always around. Only.
Just
Yes,
Priscilla,
Barb.
I just want to remind, when you're doing a total abdominal hysterectomy, it's totally open. Those instruments down, when you get towards the vagina, those are also dirty. So you have to isolate those instruments as well. And I think some of our staff have forgotten that as well. That those Alice's, that Jorgensen scissor that they may be using to cut the cervix from the vagina, that's all considered dirty. So they have to be separated from the rest of your instruments.
Right. And I think that's why those doctors like a separate closure tray. Because they are using so many instruments down below. You know, your Z-clamps and whatnot as well. Are we comfortable with what's clean and what's dirty? Like GYN cases, urology cases, gallbladder, like bile is dirty, you're never gonna wanna use those kinds of instruments to close with. Does that make sense? It's not just colon. I mean, even in Mel's cases, right? You're doing flaps and you're doing mouth, ENT things, and your flap is clean, and your mouth and your ENT stuff is dirty.
For GYN, I firmly believe everybody is doing, clean closure trays. So, when they're done with the surgery, they're, retoweling, regowning, gloving, and coming back to close with separate instruments. In the olden days, in the dark ages, when we did not do that, when Dr. Ziegelborn was not here, we had to separate and isolate the instruments, the Jurgensen, the needle holders for closing the Alice's, or the knife handle, the long knife, number 3 knife handle, number 7. We had to. We are not doing that anymore because when they are done, they are stepping away, they are regowning, regloving, and they are coming back and using a new suction, a new Bovie, clean towels, and they have clean instruments for closure.
I say similar to colorectal as well. I mean, they're doing the clean closure. Some doctors are breaking, regowning, regloving, new suction, new Bovie tip, and a lot of this is in here, like the AORN recommendations, AST recommendations are all in there. They're a little different, but it's all listed there. And then what I do is at the end, listed at the end. But yeah, it's all pretty much the same. Whatever you are closing with must be clean, and if it's not, call for something that is, right? If that's your incision, you don't want anything that has a liquid that you don't know closing your skin. We want to prevent infection. We want to prevent metastasis. So if you don't know if it's clean, just call for something new.
Priscilla, are all the colorectal guys using closure trees or not?
Yes. And they all expect that you're doing it. They're not doing it. They may tell you something's dirty, but they're not going to remember that what they gave you was dirty. They're so focused on what they're doing. And oftentimes, if I have nothing, then I don't have that's clean. Do you want me to call for another one? No, give me something else. Okay. Then that's when you're like, this is what I have. Okay, I'll use that. Because they don't know. They don't remember. They don't know that you have 4 Babcocks and that every single one is dirty. Because now they need a clean one. So just communicate with them. Let them know, hey, they're all dirty. Do you still want it? No, give me an Alice. Okay, perfect. I have an Alice. Good. Yes.
How do you handle the residents that take their dirty stuff and throw it in your stand?
Oh,
Huh?
why give them a look?
People are throwing dirty stuff on your mail stand?
Not recently, but in the past. I've had them like, they have dirty diesel drivers, dirty this and that, everything.
They should be handing them back. Tell them, don't do that.
Well,
Seriously.
If they do, that's
No, a lot of the interns have been doing stuff. It's like, hey, hold up here. This is not what we do. And they just need a friendly reminder.
yeah, we need to communicate with them, like, please don't do that, or if it does happen, that's why we use that green towel at the end. Always have a clean surface to close with. And I do see some people bring this up. I find that it's hard to look, I'm a little shorter. It's hard for me to look in and see, like, for counts, what's in there. So if you just lay it out, it's a little bit easier for people to see and count, as well as the dirty basin. If you have a towel that's rolled in here and you have a few instruments laid out for counts, it is so much easier to just point at something. Okay, I have 1, 2, 3, 4, rather than having them all like that. Metal looks so much alike. When you're staring at it, you're like, wait a minute, what is that? So try to stay organized. It really is helpful for counts. Any questions from our new people? You're gonna hear dirty, clean a lot in every specialty, like I said. We have it everywhere, it's not just PAL. Also, another recommendation is I set up for a possible dirty case for every case, any abdominal case, because you just never know. Things happen that we don't plan for. So if you have it already set up, then you're good to go.
Can I just say, with the ortho, the X-Fix, if you're gonna remove that, you wanna have a separate mail. Some people will some of the docs will take as much off as they can before they prep, but some will leave it on. So they prep what they can, but when you start taking pieces off, some of the rods will not be sterile. So that's why we have an extra male to throw
Thank
that
you,
on instead of laying it on your table.
Absolutely. Yes. Putting in, yeah. Thank you. Perfect. Is there any other specialty that maybe I don't get in pretty often enough that you guys do things that we can bring up to our newer staff? Dirty, clean? Thank you. Anybody wants to stay, I can go over anything with you guys. Any questions? Any questions for Drew? Any stapler issues?
Yeah, I was gonna say, I'll be here with, I got a couple things here for you guys to be able to play around with, staplers, talk to me about anything, issues you've had. Happy to walk through anything with you, troubleshoot stuff as we go. Well done, Priscilla.